So in my everyday role, I'm the vice president of human resources at CoxHealth. So, you know, there are some concerns. I think maybe the single biggest one that we face, and I think all of you do as well, is the coming cliff with enrollment graduations coming out of our public institutions, right? I mean, we know we're going to have significantly fewer students coming into our pipelines. And so how are we going to pivot our models and make sure we're taking advantage of the skill up opportunities that exist in our workforce? And I think we're actually uniquely prepared to do that in healthcare. We have a number of people who take everyday roles that we need in order to be able to sustain great patient care. And these are people who have not necessarily been able to unlock their full career potential. And I think through partnership, we have a unique opportunity to be able to skill them up and move them into some of these higher paying quality jobs that can stay right here in our community.
Hi, I'm Jill Williams with Missouri Hospital Association. I have to tell you guys, I brought notes because my daughter gets married in 2 weeks, so I have wedding brain. My brain is in 1,000 different places right now. A couple things I wrote down to mention too, in addition to what Andrew said, was burnout and stress. So I think we're going to talk about that a little bit later, but you guys know that, you know, our healthcare workers have been facing immense stress and burnout. Just the work itself, it's long hours, it's emotionally taxing. So that is another concern that I have. As looking at the state as a whole and thinking about Missouri Hospital Association and what some of our roles is, I also think about what happens in the Capitol and with our legislators. So, you know, there's ongoing debates about the scope of practice. So that's something that we're always trying to keep an eye on, especially when it comes to nurse practitioners. Also in Missouri, there's a lot of regulatory and licensing barriers that I feel like, again, could be improved and streamlined, not only when it comes to, let's say, physicians in Missouri, but also when we're looking at those foreign workers. So foreign healthcare workers, and making that a more efficient process for any individual getting into a healthcare career to have a more streamlined process with their licensure process.
Aaron Light, Dean of Health Sciences, and obviously my response is much more from an educational side. The shortage, we can scale up, we can teach in the classes, but our biggest thing in all the healthcare entities is where we're going to put them in clinical. Having enough clinical slots to actually be able to do it. Having a big classroom is easy enough. Finding students to fill the classroom is a different story, but the classroom part, the lab part, the funding for the equipment, we've been able to get that. It is honestly, it's the number of clinical slots. A big concern for me is stories that you're hearing about rural hospitals that are closing down. Well, those rural hospitals closing down, while that might only be a couple clinical slots, you get a few of them that do that for a program that can be completely decimating their clinical rotations. So for me, a lot of the shortage and the issues of being able to meet those shortages has to do with clinical slots.
Okay, to kind of spin off what Andy was talking about, given the reducing high school graduation numbers across the state, what can we be doing or should we be doing to attract adults into healthcare, and how do we attract them outside of other industries?
I guess I got the mic, so I'll start on this one. My thing really is, and this is where we do have to change the focus. The focus a lot of times for the past 20 years has always been the high school students being the pipeline. We have to change our focus out of that and realize what can we do to get that retail person into healthcare. That's normally going to mean we're going to have to change our delivery method. The traditional model of Monday, Wednesday, Friday from 9 a.m. to 3 p.m. type classes does not fit what those individuals are looking for. We also need to look at, and it's going to be a question down the road, healthcare, childcare, things like that. Those are the things that those individuals that are working in retail are going to need. So working with not only the educational institution, but with partners like CoxHealth, the actual industry partner, what can we do to partner together to reduce those at all possible?
So let me give you maybe a real life example of how that has played out. So we have medical assistants that work in our clinics, These individuals, for all intents and purposes, are the lifeline for our physicians. They're the ones answering the phones. They're the ones doing medication reconciliation requests. They triage everything through the clinic. If you take one of those individuals out of a very busy clinic, the entire clinic can shut down. That has the effect, when it's multiplied across our institution, of essentially bringing hospital operations to a halt, because those individuals are making referrals into the hospital for sick patients and getting them the care at the time that they need. So not having MAs is akin to a death sentence for a health system. Historically, individuals were going into that profession. They're not necessarily now. And there are a number of reasons for that. A lot of it is many people don't even realize that that profession exists. They don't realize that it can be a lifestyle profession for them. They can be off on weekends. They don't have to take call. So we literally over the last few years saw our application counts virtually dry up. We immediately had to figure out what we were going to do. And so I actually reached out to these guys and said, hey, what do you think about starting grow our own program? We put our heads together. It's a certification process. We found a way to significantly expedite the program and dropping it from traditionally a year program down to a few weeks.
16.
16, yeah. And
we're good, but not that good.
we'll keep pushing you. Yeah. And so we now had to fill that pipeline, right? Where we need to push people into this profession. Well, we had a number of people that were already working our clinics in frontline roles that would have loved the opportunity to be able to become an MA. But life happens. They have kids, they have family things, they've got an inability to be able to afford to go back to school. So we systematically began addressing those barriers and breaking them down. And we have a fully certified program with the Department of Labor now. It's an apprenticeship program. We have put 300 to 400 people through that MA cohort over the last several years. And we now see about 51% of the medical assistants working across our enterprise, 90 plus clinics across Southwest Missouri, are from that program. They have a better clinical rotation. They come out better prepared. And we see that our physicians now are clamoring for those individuals because of how solid they are, and they're staying. So the retention is significantly improved because they're better prepared and we've invested in them. And so we now actually pay them to go to school. And that sounds so radical, but if you think about it, what is a 16-week investment on someone when the alternative is that you're out of business? And so I think we have to think differently, to Aaron's point, about how we break down barriers, drop in daycare. We have 3 childcare locations across our enterprise. We've got capacity for 500 kids at any time. So we've systematically broken down those barriers, and those individuals feel much more invested in as human beings, and they feel like we are truly a best place to work that's living what we say we will. And honestly, we could not have done it without OTC. They've been great partners, and there are a number of other apprenticeships that we're bringing online in that model. But again, we as employers have to do more to work with our colleges and universities to help them understand the need, and then get collaborative with you all on how we pivot that.
All right. A lot of what I have written down has been already said, so I'm glad I have notes with me today. But again, when it comes to education, just offering that flexible scheduling, online courses, weekends, nights, days, not only though when it comes to their learning, but when it comes to clinicals, I think sometimes hospitals can do a better job of offering different clinical times, whether it's nights, weekends, et cetera, for our students. Again, the financial assistance, childcare, elder care, those are very important for attracting adults into our healthcare careers. Was mentioned about fast track certification. So what are those short-term training programs how can we fast track those and get their foot in the door and get them trained? But also, again, like with apprenticeships, earn while you learn. We have got to pay people while they are learning. It's just the way it is. There's no more post a job and pray because that's not happening anymore. We're not getting the applicants that we used to, especially through, well, for one, our demographics are shifting. And so we don't have as many people for the jobs that we have open. But again, also we have to do what we can to attract all different individuals into healthcare careers, but we do have to pay them. I think about myself, could I just quit my job and go to school and be able to pay bills and support my family? No. No longer are the days that we can continue to, as a hospitals, take students in and they're doing their clinicals and they're kind of doing them for free. And we get like a free extra hand in the facility. So that's how things have been in the past. And I think that trend is changing because it has to. I was talking with Dr. Hubble in the back. We talked this morning, and one of the things we talked about is the average age of our students in the programs. We're looking at 28 to 30-year-olds. It's not that we're not talking about necessarily the 18, 19-year-old just out of school, maybe living at home or their parents paying for their tuition and their bills. These are adults with financial responsibilities and families. So we have to think about that when we are in the learning process and training them for the jobs that we want them to have. Also, again, from an advocacy and policy standpoint, we need to support adult learning through legislation. And that's working with our departments of government, like Department of Higher Ed, Workforce Development, Department of Economic Development, to work together to create programs that are sustainable to help fund these students to go to school, these adults, specifically adults, to get back to school and to learn. And again, our job to attract them into the healthcare field. And then the last note I made was promoting that diversity, equity, and inclusion and belonging. And that's another great way to attract adults into the healthcare field. And I think we'll talk about that a little bit later with one of our questions. So we can kind of go into it more then.
Well, thank you. So to kind of wrap back up to what Jill was talking about earlier about burnout, how much do you feel that burnout was the primary cause of the current shortage?
Since I have the mic still, I'll speak, but I do think burnout was a contributing factor to people leaving the healthcare profession, but I don't think it was the sole factor for people leaving healthcare. It was a tremendous time during the pandemic. We still have people, sometimes I feel like maybe even myself included, a little bit of PTSD from that time of just working. It was very long hours. It was very taxing work. A lot of our health caregivers, especially those on the front line, were really facing a moral distress at sometimes and having to help some families and watch families make very, very tough decisions. But since then, things have lightened, but the stress and that emotional toll just kept coming in waves. It was like we thought we were getting through it, and then it hit us again. And we've recovered somewhat from that, but never fully recovered because the demand for healthcare services is still just so high. And through that time period, we had a lot of retirements. We had a lot of people take leaves of absences or leave the profession altogether. So we're still trying to recover from those shortages that existed at that time, but then still continue to exist today. See if there was anything else I wanted to mention on that. Oh, just something else that sometimes you don't think about if you're not in the healthcare setting on the front lines, but the increase in the prevalence in workplace violence, especially in our emergency departments and some other departments within our hospitals. But workplace violence has really increased over the past few years, and our employees' safety is most important. And especially, just anecdotally, what I'm hearing from our healthcare workers, those that have been in healthcare for a long period of time, are kind of, and I hate to even use this word, but they're like used to it. They're a little bit more hardened to it. But these nurses that are coming into our healthcare system today, we're seeing more that they're not going to put up with this. So we're seeing more of them, filing complaints or grievances or working with the police, or even if they're called to go in and testify about an assault or an incident that occurred, they are going and they're showing up and telling their story. So I do think that's can be another cause of burnout, especially with those new nurses within their first couple of years that maybe weren't expecting it to be that way, or just didn't realize what, especially in specific departments, what that workplace violence can really look like.
She said everything I was going to.
I don't know that I could say it much better than that. I think when we talk about workplace violence, we're talking sadly about some realistic job preview. It is the deck is stacked against us. We see that especially pronounced. It's across the nation, but it's especially pronounced in Southwest Missouri, where unfortunately we see higher rates of assault and domestic abuse. It's more nuanced into the fabric of life in Southwest Missouri, unfortunately. And I think for newer grads, whenever they're starting their career, it's a shock factor. And we've done several things to try to mitigate that, including we have canines in our facility now. We have badge activated RFID alerts so that we know exactly where someone is at. So if they get cornered by a patient in a room, we can have a team that descends immediately within that unit. But even despite those things, our people still get beat up. And I think that's, how do you attract someone into a field where you tell them, if you fight back, you will lose your license? Okay, so you just want me to get beat up. There's an abandonment factor there that employers are going to have to address, and some of that I know with MHA we've got to work legislatively. We know individuals have been reticent to come forward and file those charges because they wind up getting named on that police report, and then they are public, and they fear that individual getting out and coming after them. So we've taken a series of steps at CoxHealth where we actually will back them up. We will file with them on their behalf and press for those felony assault charges. So we have a lot of work to do on that. I think the other factor that we have to keep in mind is COVID was a war zone. I think you said it so succinctly, Jill. But we're now looking down the barrel of the largest mass exodus of workforce out of our society ever in our country's history. It's never happened like this before. So when you have 180,000 baby boomers retiring every day for the next 15 years, they also are seeing their care needs increase as they get older. So it's putting additional pressure on those of us who are still in the facility doing the work. So not enough people, but our workload is doubling. And so, that's a big challenge for us too, that we're going to have to address. And there are things that we can do. Having folks work at top of license helps. There are a number of things that we'll sometimes have people doing that we've historically just done it, but it doesn't necessarily make sense for their profession. It can actually be a big drag on them. It can be, kind of soul sucking at times of the very tedious things that maybe automation could play a role and help us. So we just have to reimagine work across healthcare, and we have to do a better job for the students that are in high school about reaching them earlier in their academic career and showing them these other modalities. I think everybody naturally goes to doctor, nurse, very important, but there are other professions that are very, very essential for us to be able to run a health system and provide care for our community.
So what ideas do you have about attracting a more diverse workforce?
You want to lead us off?
I got a list on this one.
I know.
I'm sure I can start. Definitely number one, targeted outreach. So how can we, as hospitals, organizations, recruitment teams, target those groups or outreach to underserved populations? And that means attending job fairs, career expos in diverse communities. But not only that, but also just as an organization participating in local community events. There are people in diverse communities or with diverse backgrounds that don't trust healthcare. So they need to see healthcare professionals out in their community. Also, diversity-focused scholarships and grants, especially for underrepresented minorities. So collaborating with maybe foundations or organizations that offer those financial supports for diverse students. Within the walls, establishing not only in our hospitals, but in education as well, establishing those partnerships and preceptorships, mentorships, and pipeline programs with those minority students, and introducing those middle school and high school students, especially from those diverse backgrounds, to careers in healthcare so they can start to see themselves in those roles. Also, of course, when it comes to marketing, thinking about our ads and how we publicize ourselves through our websites, our billboards, our commercials, showing our diverse employees working in those roles. And then when individuals interview, having a diverse interview panel, that also helps with kind of keeping out that unconscious bias as well. And also integrating diversity into the curriculum. So integrating that into our health education curriculum. And then I think too, as an organization, whether it's school or hospital, setting those diversity goals, tracking those outcomes and making it something that is continuously reported on. So not just, oh, these are some goals and, we hope to get there, but really tracking the progress, making it a part of monthly meetings or report outs or whatever it may be, to really hold ourselves accountable to trying to reach those goals.
So I'll just talk about two things. One kind of a larger one and one more what I'd kind of consider low-hanging fruit. The larger one being the distrust that a lot of minority groups have with healthcare. That is something that collectively education institutions and industry partners need to look at. How do we break that down? How do we actually get those communities to trust healthcare? Because there is a long-standing reason for why the grandmothers, the great-grandmothers tell the stories down that generational line of don't trust healthcare, you don't want to go into healthcare. We have to figure out a way to break that down. That is a much larger one that's going to take more time and effort to do. To me, some of the lowest hanging fruit stuff is something that I noticed when I became dean 2 years ago, and be walking around Lincoln Hall, our building, and you would see a lot of photos up on the wall. You would see graduation photos on the wall, and it was great. You were recognizing the graduates of the program. The problem is here in Southwest Missouri, the predominance of our graduates are white. Predominance of our graduates are female. And if you really wanted to have some fun with it, because I got bored one day and started walking around and counting, many on the wall were 20-year-old white, blonde females. And the ones that were put up on the wall in these large posters, they were put up there because they were attractive. And it's like, oh, this was a great photo. Now put yourself in as the minority person coming through. You walk around the building. Do you see any place for yourself? Do you see yourself in any of those photos? And it was something that was never intended with what was being put up on the walls, but it was basically a macro aggression on the wall, slapping them in the face every time they walked in and around the hallway. So that's something that I know we have done in our building. When we do the tour, you're going to see no photos up on the wall. That's changing. I just haven't had the canvases made yet. But what I did say is we're not going to put those graduation photos up, not because we're not proud of our graduates, but because it creates a barrier. And then any new photos that go up will be of a more diverse group, not only in color of skin, but also in gender as well. Because in healthcare right now, in most of the healthcare professions, it's about a 2/3, 1/3 split So it's about 2/3 female, 1/3 male, and in almost every single profession except for EMS and paramedic. And they flip the other way. So we have to be able to do that. And that's a low hanging fruit. That wasn't easy enough for me to go, we're making that switch.
So I think those are great points. It's an issue that takes time, first and foremost. You have to start with a foundation of trust. And when systematically over generations, that trust has been abused, it takes a long time for those scars to heal. And we just have to recognize that, we have to own it, and we have to take proactive steps to show what healthcare really does have to offer. I mean, if you just imagine the healing arts, I mean, it's outside of education, it's the highest calling there is, right? We literally save lives. We get to heal people. We get to make a fundamental difference in someone's life every single day, whether we want it to be good or bad, it's going to happen. And I think through that outreach, we have to have individuals that represent me. And from me, I mean the community's perspective. So I know you're going to talk about the Alliance a little bit later. So, you know, one of the things that we found in our new partnership with Springfield Public Schools, OTC, Missouri State, and CoxHealth was that every single year, Springfield Public Schools graduates 3,000 seniors. They're the largest public school district in the state, 25,000 students. And we have 1,000 of them that immediately do not seek any other advanced education. We've got 1/3 that go direct to workforce. Many of them are from underserved, underprivileged areas of our community. What an awesome opportunity to be able to partner with the school district and show these kids early on that healthcare can be trusted, that it does provide a really good quality of life, that you can continue to contribute in your community that you love, and you can partner with a healthcare institution that will help you achieve those goals. Again, that's going to take time. That'll take years, but systematically, because we're going to be consistent and because we're going to bring in those healthcare professionals to talk with them at career days, we're going to give them opportunities to shadow. They will begin to see individuals who look more like them because we have them in all facets across our enterprise, whatever them might be. And we just have to be very, very intentional about curating those experiences for them and making sure that they're positive. And I think that's a recipe for success. But it will take time, and we just have to recognize they have to see opportunity. And I think for all the reasons that Aaron highlighted, that sometimes unintentionally, despite what our best intentions are, we can send the wrong message, and then we're sitting there trying to figure out why our classes aren't full, why individuals aren't applying, why they don't seek care with us. We have to get to the root cause of that.
Do we want to see if they have any questions?
Yeah. Does anybody have any questions for the panel at this point? Or any comments they would like to add? You don't need to bring the microphone. Oh, sorry. So everybody can hear you.
Thank you. So I just have a thought about burnout, and when we talk about violence in the workplace, can we talk about a little bit about lateral violence as well, and perhaps more seasoned nurses and the nursing student relationship?
I mean, you don't want them to eat their own? This is one thing that I think is and I can only speak to healthcare. That's all I've ever done. So it might happen in other industries. I don't know. But healthcare, we are pretty bad about eating our own. And a lot of times that is a historical thing. They were beat down by their preceptors who were beat down by their preceptors, and so on and so on and so forth. And that is something that for me can be dealt with on the education side of letting the students know that that's not acceptable, that's not right, and that they should not stand for it. And if they have those events, to be bringing them back to us so that the school can then address it with whatever the clinical location is. To me, it's letting them know that that is not proper. That is not how things should go. And that's the way that I think the educational institutions can help break that trend. And I'll let Andy talk about it from a kind of an industry hospital side.
Well, I think we can sometimes be our worst enemies, right? So because of shortages, we force people who maybe aren't good at precepting or don't want to precept. You have to, right? So naturally that's going to breed some resentment, right? So nurses have a really tough job. Healthcare is inherently very challenging. You can exacerbate that whenever you force them, right? So I think some of the models that we've been doing are leveraging who wants to precept and then setting systematic expectations for them on what that clinical experience has to look like. And doing it with a more controlled group gives you an opportunity to be able to single out when there are issues that exist. So instead of just forcing them to take them, find the people who want to do that and make it a positive experience. The other piece is helping everyone in the workplace know that where an individual has a positive clinical experience, overwhelmingly 9 times out of 10 is where they're going to choose to practice. So it's sometimes you have to tough love it a little bit, and you can't be smarmy about it, but it's helping them understand, do you like working short? Do you like doing mandatory overtime? Do you like having larger patient loads and feeling like you aren't giving the best care that you're possibly able to? No. Then stop being a jerk. It's very easy. Like, make them want to work here, right? And so we've tried to take a more proactive approach to how we do that. I would love to say that we've got it all figured out. We don't, but we're at least taking those steps right now to make sure that experience is good. Because I can tell you through our alliance, we need to double the number of students that we're producing through our respective institutions today. And so the message overwhelmingly that I've sent to our directors across the enterprise, you have to figure out a way that you're going to double the number of students that are precepting through your programs, because it's coming. You can't continue to tell me anymore when I say you need to take 40 new grads and you say, well, I can only precept 25. Yeah, but you need 40. So if you don't do it now, you're going to need 55 or 60 by the time you anger everybody else and they wind up leaving. So it's really helping everybody understand the full picture and making sure you have alignment and working toward a common goal. We all want to make sure that we can go home to our kids at night whenever our shift is over and not have to worry about whether or not the care that we provided was subpar that day. The way to do that is making sure they have a good clinical experience and they naturally say, that's my person, that's my unit, that's where I want to stay.
Great question and great answers. Yes.
This question may be beyond the scope of this panel, but I really liked when you said the earn while you learn. And I'm coming from a PT assistant program, and I see some OT assistant program faculty there as well. That is really difficult in our programs. And especially like they're paying tuition while they're going out working. And this is always like a thing that I feel like it's not in any other professions. So I don't know if you have any thoughts on that.
Let's wait a couple lectures and I'll answer that. I'm actually going to be talking about apprenticeships and ways to be able to pay and earn as you learn type of situation. So I will address that. Healthcare, we don't do a lot of apprenticeships. Most of them are construction based, and that's something that we just need to get better in. But I will address it just later.
Since Crystal and I work together on the same campus, I'm going to build on her question. So the question she asked was about eating their own. And we're talking about bringing new people in. But what are the hospitals doing to keep their experienced nurses so you have those nurses for preceptorships?
Do you want to? Yeah.
Well, I'll start a little bit still on her question, but I think we'll hit a little bit of yours too. So from experience, I'll tell you, I have a daughter, the one that's getting ready to get married, and she's a new grad nurse. I'll still call her new grad, but she's been a nurse now for about 2.5 years. And so I get to hear it at work, and I get to hear it when I talk to her at home too. So I hear all about what's going on the front lines. But she was a preceptor after 1 year. Which to me was a little bit shocking, but that's just the way it is. We don't have enough preceptors, and those new grad nurses are precepting, and they just are. And so that's something that I feel like was very interesting. But I also think, just in with talking to her about her experience, she because they're so new to the job and new to precepting, she's wanting that experience for her student to be the same or better than hers was. So whereas a nurse who's maybe been in for 20 years and is precepting and is kind of the burnt out on precepting, and this is just another student, some of these, I think the brighter side of newer grad nurses being preceptors is that they're still typically, positive, they're hungry, they want to teach, they want to show people the skills that they've learned and show these new students their skills and teach those skills to those students. So hopefully over time that will change kind of that eat your young mentality. And then also, again, I think Andrew kind of alluded to this on the recruitment side. So I think our recruiters need to not just hire and let go. We need to make sure our nurses have a really great onboarding process, and not only in the recruitment and onboarding phase with HR, but then also with the nurse leaders, and telling that story of, if they don't have a positive experience, they're not going to hire on here. And that's just the way it is. So, that tough love of it's good. You are recruiters. You're recruiting these students every day to come and work for us. And then the last thing is really just training them. Missouri Hospital Association, we have a preceptor academy. We just actually held one earlier this week at CoxHealth, and we had 80 nurses go through that training to learn how to be a better coach, a mentor, and a guide to orient new students to the hospital and to their new roles.
Yeah, so I think in addition, we have a very heavy focus right now on retention, belonging. It's great to bring new people in. Don't get me wrong. And grad nurses are they're a lifeblood for us that keeps us fueled, keeps us going. But we have a number of things that we're doing with our experienced nurses as well. We recently pivoted an algorithm on how we determine compensation increases to make sure that it's more representative of those who have tenure. So instead of doing a standard 2% across the board, for example, we have graduated increases because the compression that they were feeling. We did a new event. So we've done sort of a experienced nurse reception event for several years. And we didn't get to do it through the pandemic. We decided to bring it back, but we wanted to kind of breathe new life into it. So we, for those of you from the region, Finley Farms in Ozark, it's the Ozark Mill, historic mill. Johnny Morris bought it many, many years ago, has done amazing work to transform that property. And it's awesome. So we did an invite for all of our experienced nurses to come to the mill in Ozark, which is kind of a good intermediary between Springfield and Branson, recognizing we have hospitals in Lamar and Monette. We paid for transportation for individuals from the outlying campuses to bus them in. And we just rented out Finley Farms for the night just to say thank you. And we curated different experiences so they were able to do some things like write a thank you card to a mentor that they've had that was instrumental in their life. They were able to do like a flower bouquet decorating thing. We had some other things for maybe the more manly individuals because not everyone wants to do flowers, right? So it was a cool experience, and we bought them drinks. We bought them appetizers, and it was just a good night just to say thank you. And we had around 450 nurses come to that. It was the most we've ever had. It was one event just to say thank you. But it was a lot of fun. We had a blast. And so we're constantly doing things like that for them, just to say you matter and we see you. In addition, we do DAISY. We're a magnet facility now. We have the DAISY equivalent for the support aides as well. And just doing everything we can along the way to do a formalized recognition program for them.
No pressure, Dr. Light.
Well, retaining older staff as far as nurses on the clinical side isn't really anything that I partake in, but here at OTC, it's trying to recognize their ability and figuring out what else can we do to support you in your growth, whether that's going on to get your MSN, you're going to get your nurse practitioner. We've been working on some remote contract stuff for people, which is something that from an educational world right now, we're the only division that even has that. I've got other deans going, hey, what is this agreement? What did you? We're trying to work in that area as well to offer up to individuals reasons to stay and to keep working at OTC. So a lot of times it's creative because what a lot of them want is the more pay, and that is something that all administrators kind of butt their head up against because you've got a budget, but it's like what else could be offered, what could be provided to an individual to make it to where it's still a benefit, but fits into a financial plan that we're all beholden to.
One more thing I want to add to that retention piece. I was sitting here thinking if I could say like 3 things that overall I see hospitals doing to help retain nurses or any staff in the hospital. We're seeing a lot more requests for flexibility. So definitely flexibility, that work-life balance is huge. And so hospitals, trying to work and pilot different programs to offer flexible schedules for staff. Also leadership and management training. So there's been a big focus as we've came out of the pandemic on training, not only to advance individuals through their own career pathway, but training our leaders and managers on how to support their teams. And then the third thing I wrote is a voice in decision-making. Our healthcare workers, they want a voice in decision-making. There's a term used in healthcare called scrub versus suit decision. And we're trying to change that shift to where the scrubs will say those in scrubs have a large voice and a loud voice in the decisions that are made within their organizations.
Well, thank you so much, Jill. I love the Preceptor Academy idea. I was precepting at 6 months as a new grad. So yeah, I know exactly what your daughter's talking about. That's crazy. So before we wrap up the panelists, do we have any more questions or comments from the group? Thank you, everybody, for your participation and questions. And thank you to our panelists.